Yeah, it's coming, and we're seeing.
Okay.
Let's give it a second, but it's looking promising. There we go. Yes, we can certainly see your screen now, so I'll go off camera myself.
Okay.
Go ahead, sir.
All right. Can you still see it?
Yes, we can still see it.
Let's see how this will work, because I wanted to show some interactive elements. Okay. Good afternoon, everybody, and I'm so glad for this opportunity to be able to be here. I apologize for the noise in the background. There is some electrical work being done in the corridor behind. Apologize if I'm a little bit fast. I hope. See, when I was I brought the connection cables. The American Canadian connectors do not match the South African plugs, and nobody has been able to find, or I have not been able to find a good adapter. So I'm working on. Currently, it says 43% battery. So I hope that will last our discussion today. I think it will. I don't intend to be too quick, but I mean to be too long. That's what I meant to say. So let me dive into this. What we want to see today would be to see, as I said, I want to present an overview, just a brief overview of the CanMEDS framework and the workplace-based assessments that's based on it. And then you'd like to examine the factors that impact creating authentic WBAs, workplace assessment, that is the principles that underlie creating authentic WBAs. Also, I would like to then undertake with all of you what I call a quasi-Delphi exercise. And you'll see why I call it a quasi-Delphi exercise. I'm sure many of you are familiar with that process. And then finally, we'll discuss and take questions or find our concluding thoughts. So I wanted to, this is where I wanted to do some interactive activity with you, what I call a connecting with you with an icebreaker activity. Let's see if this will work. Okay, so this is where, so normally this should be showing you let me see, will it work? No, it's not. Let me go back a second. I don't know how to actually bring in the interactive elements, which is a shame, because a lot of what I really want to show you is interactive. And so Teams, this platform is not allowing me to. Let me see if I can pop out and see. I'm going to depend on you to let me know whether you are still.
Yes, if you could just perhaps just to potentially, let's try. If you are in slide presentation mode, slideshow mode, and
Yeah.
and then if we had a link to click on it, or even to post in the chat, then there'll be a particular code that we need to enter once we're in the site, is my understanding of it. If we go into, I think it's www.slido.com, or I'm guessing now.
Yes, See, when I go into slideshow mode, sorry to interrupt you. When I go into slideshow mode, then I don't see you or anything. It just fills my screen, so I can't access Teams any longer.
Do you have the particular code relevant to the?
Yes, I do. It's where is it?
I wonder if that's easy.
Just a second. I wrote it in my notes.
Richard, if I can jump in and just say
Yeah,
that
please.
if you stop sharing your slides and
Stop sharing.
go,
Okay.
you stop sharing the slides and
Yeah.
then open another tab on your browser and open Slido. Open your saved presentation in Slido, your saved set of questions.
I see. So I should go
Okay.
into the browser and
Yeah, open a new tab.
yeah,
And then you
just
can
operate
go back
from
to the
there.
browser. Yeah, go back to the browser and go back into your Teams meeting link. And when you hit share, rather than say share presentation, share the window. And you can share your Slido window and we'll be able to see your Slido questions and respond to them from there.
I get it now. Okay. Yep, that's where I was using these the integrated Slido with the PowerPoint.
Yes,
which is
yes. So
was
that only works when you've got it actually in presentation mode. But if you share your screen with the Slido on it, then we'll still be able to interact with Slido and you'll still be able to see.
okay.
Okay, I'll butt out now.
Thank you. Thanks. There you go. Okay, so I apologize for this.
No, not at all.
I'm so used to I'm so used to window. Can you see my screen now?
Yes, we can join at slido.com, and then you've given us
Yes, and that's
the
the
number,
code.
the
Yes,
hashtag, the code.
1583155.
So we will in turn open another window ourselves, Shayla, and go into Slido in that way.
Yes.
I mean,
so if you open
sure.
another browser yourself and enter this code in the panel on Slido. Slido enter 1583155. All right. So this is my first icebreaker question. Where are you joining this meeting from? Office on campus, office within the hospital? Are you going in from home, somewhere else? You wouldn't believe it if I told you. 100% everybody is on camp. Oh, okay. Somebody. Excellent. So I'm glad that somebody has a sense of humor. Okay, so I'm going to pause the poll for now, and then let's go back to the meeting, and then I will show you my my presentation. So we go on. All right. Resume. Okay, we've gone past this. So the CanMEDS framework was developed in the 1990s by the Royal College of Physicians and Surgeons of Canada. And it was designed to align specialist training in postgraduate training with social needs as a responsive and socially aware type of curriculum that aligns this training of doctors and physicians to that of what the society actually needs. And I think South Africa is also always, as far as I remember, have also been brainstorming that type of curriculum to have a curriculum that trains medical doctors in the areas where they actually needed by society. And so that's what the governing body of medical doctors in Canada, the Royal College of Physicians and Surgeons, that's what they undertook in the mid 1990s. And as you probably know, that all doctors in Canada, all practicing physicians are specialist physicians. In other words, there is no exit level practicing physician. So if you finish your first degree, as it were, your 4 years of MD, that just qualifies you to undergo specialist training. And so that you will understand, therefore, why this was targeted at that level, at the level of the specialist. So that's what the CanMEDs mean, the Canadian Medical Education Directives for specialists. And there was a body in Ontario. Ontario is the largest province in Canada, and Ontario educating future physicians for Ontario. They then furthermore distilled what the tasks, the behaviors, the observable behaviors that were listed in the CanMEDs. They then distilled it into their seven roles that we can see here. They did that with the broad consultation with the literature. So they looked at the literature. What are the roles that doctors are meant to perform? They looked at both published work and the gray literature, the unpublished work. They conducted focus group meetings. They met with educators that have been teaching for many years, medical educators, and all of that broad-based interaction and broad-based consultation led to the emergence of these 7 roles that we see here on the left, which are that of the medical expert, the professional, the scholar, the health advocate, the manager, the collaborator, and the communicator. So these are overlapping roles, as you see that the leaves of this diagram all overlap each other. In other words, the competencies that will be derived from here, a manager, a medical doctor who is able to manage, say, an office, or who is able to manage a department in a clinical department, will also be somebody who is a health advocate, will also be somebody who can collaborate with professionals, similar professionals or allied medical professionals, and so on and so forth. So these roles are interconnected and they are overlapping. And the CanMEDS framework has actually been validated across many disciplines and across many countries. And so we know that they are valid. They represent the roles that doctors and physicians are actually meant to perform in different contexts. So these are what we call, sorry, this is going to be very, like the font is small, but this diagram or this table is actually from one of the papers that elaborated on the CanMEDs roles. And the reason I showed you this diagram, this table, is to say that under each role, so the one you can see is the medical expert. Under the medical expert, you have what they call key competencies, so that what the specialist must be able to do. So for example, I'm just going to go over this one, and I'm not going to go over the others. So you have the medical expert, so a physician who is graduating at the specialist level, no matter their specialty. So they may be a surgeon, they may be an orthopedic surgeon, they may be a physician, they may be a gynecologist, whatever their specialization, this medical expert, this physician will be a medical expert. And what they will be able to show is that they will be able to demonstrate diagnostic and therapeutic skills for ethical and effective patient care. They will be they will be able to access and apply relevant information to clinical practice. They will be able to demonstrate effective consultation services with respect to patient care, education, and legal opinion. So they are experts in patient care and in clinical practice. And under all the remaining 6 roles, you also have those similar description of the key competencies. So like you have here. Now, arising from these key competencies, then you have what we call enabling competencies. So the enabling competencies are what are usually described as the outcomes. So this is what we actually observe at ground level. So this is what actually a physician will be able to, if you go into the hospital, this is what you will see a physician doing. And to illustrate these enabling competencies, I have 2 just brief forms that I'd like to share with you. These are what we use at UBC, these 2 forms. This one is for CBL. We call it a workplace-based assessment, even though case-based learning is technically not a workplace, but it is a simulated workplace. It is a type of workplace in the sense that students are around a table or in a room, and they're put, a scenario is put before them as if they were the physician or they were the consultant, and they're the doctor in charge, and they're being asked to describe what they would do. So in that sense, that is a workplace that the students are in, and therefore we have developed workplace-based assessments that show the enabling competencies that we would like our students to be able to demonstrate. What I did was I'm going to scroll through. So you can see I recorded myself scrolling through our assessment form. And there are 3 key areas where we evaluate students in CBL. One, we want to see their teamwork. Are they able to collaborate with their teammates? Are they able to engage with one another? Are they able to allow one another to talk? Are they able to, and we calibrated this teamwork at a year 1 level and at a year 2 level, as you can see scrolling down there. And at the bottom of each of those competencies, you have a global scale, a global rating, where the person is just okay, or they're doing good, or they're actually excelling. And then that moves on to the next enabling competencies, which is communicating. This is the communicator role, or the CanMEDS communicator role. And again, the described activities or described behaviors that we would like to see. Is this person able to talk to a patient? Are they able to communicate with colleagues? Are they able to cite critical primary literature and explain what the literature is describing? And again, you can see global scale there at the bottom, whether they need more help or whether they're actually excelling. And then the third area where we evaluate in CBL is their clinical decision making and provision of care. Understanding that there's actually no there's no provision of care in a CBL setup. However, students describe what they would do. So what would be your next diagnosis, or what would be your differential? What would be your next test that you will order? So we see all of those enabling competencies, and again, the global rating. And at the end of it, the tutor will be able to say this student has satisfied the requirements, or they require additional support. So this is one example of our case-based learning workplace-based assessment that describe explicit behaviors that we would like students to demonstrate, and at what level they are able to demonstrate that, either at a year 1 level or at a year 2 level. Okay, the next slide is similar, and maybe I'm not going to go into too much of that. It is this one, we use it at the end of year 3. So, but in our program, our medical degree is a 4-year program. The first 2 years are so-called pre-clerkship or preclinical program, where they do their WBA, they do their CBL, they do anatomy, physiology, they do pharmacology, but they also do clinical work. So they have clinical exposure, whereby they go into the hospitals and they go into doctors' offices, and they're just interviews. So they're able to interview patients. They're able to do small beginner's clinical work, but they don't really do the heavy lifting. The heavy lifting happens in year 3. In year 3, students are, as it were, thrown to the wolves, if I use that metaphor. They're actually thrown in at the deep end. in year 3, students become an effective member of the healthcare team. So they are distributed into the different rotations, and they're supposed to, we call them rounding. They go on rounds with the attending doctor, and they're given tasks to complete, to monitor the charts of the patient, to take input and output charts for a renal failure patient, for example, or to follow and monitor blood samples and get that back from the lab. Yeah, so they're an effective member of the healthcare team at that level. And so this form is designed at the end of year 3 to assess them. So this is the workplace-based assessment that we use at the end of year 3. And again, scrolling through, similarly, you see that there are the observed behaviors that students are supposed to meet. So again, following the CanMEDS competencies, so at the level of the medical expert. So year 3, the learner obtains a complete and focused history and is able to prioritize and organize their history. They're able to perform a focused physical examination in any clinical situation, and they're able to describe their normal and abnormal findings. So that's the consultant will be able to grade the student, the patient, and this student is not on track. They don't know how to do this, or yes, they're on track. And so on and so forth. You can see all the milestones that we expect that the students should be able to demonstrate. The learner recognizes the implications of normal and abnormal diagnostic screening tests results and responds appropriately to these results. The learner proposes and, where appropriate, implements a care plan for the patient. So yeah, so that's at the level of the medical expert. At the level of the communicator and collaborator, you have described competencies as well that the student is should be able to demonstrate. At the end of year 3, the learner participates in safe transition of care, both as a provider and a receiver with members of the other members of the healthcare team. The learner communicates with patients and their caregivers and is empathetic and reflects what is the decision of the healthcare team, and so on and so forth. The learner is reliable, shows up on time, is punctual. Those are and carries their fair share of activities within the healthcare team. So all that is measuring the learner at the level of the collaborator and at the level of being a communicator in the healthcare team, and so on and so forth. So I'm just going to move on. And so it takes the level of the healthcare advocate. So all of these competencies are being used to evaluate the students at the end of year 3. I should say that this one form is not the be all and end all. So the person who fills this end of year evaluation is usually like the head of department. We call them the DSL, DSSL, the district discipline specific site lead. All right, so the person is maybe the head of internal medicine, is the one filling this form. In order to fill this form, though, give other forms from other preceptors who have trained that particular individual. So in completing this form, the head of department is not just relying on his own experience with this student. He's relying on multiple experiences, like 7, 8, 9, 10 different preceptors have submitted forms and have submitted feedback to him about this individual student. And so based on those levels of feedback, those many multiple observations, then the head of department will complete this form. So there are principles that we can draw out about creating an authentic an authentic WBA form. And I have 3 of them. The number one is that the WBA should have a clear goal. In other words, there should be, this form is a formative tool, right? And it should not replace other forms of assessment. So it's not the be all and end all. So a student that does not do well in one WBA has not failed, all right? Because there are other avenues for assessing the student. So the WBA should be seen more as helping the student to get up to scratch in their clinical acumen. So as I said here, so it's a tool, should be a tool to provide feedback to the student. So no single WBA is definitive on the competence of this student. And the WBA, another clear goal of WBA is that it should be used to confirm a minimum competency. So it's not supposed, the student that has passed WBA is not suddenly an expert in the field. No, it's just saying that at the level of a primary caregiver, at the level of seeing a patient and taking care of a patient, this candidate or this person will be competent. The second principle about WBA is that it should have a good and authentic WBA should have a good design. What do we mean by that? It should measure observable behaviors. All right. So it's not a theoretical thing. So for example, we shouldn't make inference. And I think that's what I'm saying here. We shouldn't be making inference based on the WBA to say, in other words, this person failed his first MCQ. And so it's not likely. It fails MCQ in internal medicine, and so it's not likely to do well as a clinician. No. We don't make inference from other like non-clinical clinical work. We don't make inference from theoretical things about this student. We only judge this student based on what we have observed them do or not be able to do. Also, the WBA should be based on the local context. So it's based on the people who have actually seen this student in their local hospital, in their particular wards, or in the particular task that they're being given. So it should be based on the local context. So if you're trying to get the student to take, and I know pulse oximeters are everywhere these days, but if you're trying to get the patient to determine an oxygen saturation and there's no pulse oximeter, then you cannot safely assess the ability of that student unless you have taught them another method of determining oxygen saturation. Anyway, that was just an example. Also, there should be a narrative. Oh, my battery is running low. Hopefully, yep, I should be good. There should be a narrative feedback in every WBA. There should be opportunities for narrative feedback, and which is what I'm saying here. Multiple opportunities for feedback should exist in WBAs. And the third principle is that the WBA should be used as intended. Okay, so there should be multiple and frequent opportunities to do WBAs for students. Also, variable preceptors. There are many preceptors should give their input into WBA, because the variability of preceptors makes it more valid. And then preceptors should be trained in the use of WBAs. So and I said it should be used regularly and refined also. It should be reviewed regularly so that are refined to make it better suitable to measure what is intended to measure. And so I intended us to do 3 of this. I'm going to close this and let's see how. I hope my battery lasts. I'm on 14% right now, so it's really running out very quickly. Let me stop sharing or share something else now. Let me share the, let's go back to the Slido one more time. So let's see if we can, let's say we're trying to rank these behaviors. So when a student is, you've told the student to perform a chest examination, all right? What order should the student follow? So I chose this because I know this one is particularly straightforward. I hope. Let's see. So you can rank them. Rank the first one you tap will be number 1, and the second one number 2, and so on and so forth. Let's see. Okay. Okay. I see that we are not unanimous. So this is how a Delphi situation will work. We will send something to experts and we'll ask them to rank. And we were able to measure the percentage of experts that rank the first one as number 1 and the second one as number 2 and so on. And then we would because it's anonymous, so the Delphi will be anonymous. Then we'll return that result back to the expert. I said, this is how all your colleagues marked this exercise. Do you want to? Do you have any second opinions? Do you have any comments about whether they were right or wrong? And then that is refined again, and there's a third round where it's refined again until they achieve consensus. Usually, by the time 70% or more of experts rank number one as number one, then they have reached saturation. They feel, okay, that can be taken as valid, as authentic. As we can see here, majority of us, this is more than 90% of us, have ranked inspection as the first step in performing a normal chest exam. And I agree that should be correct. It tends to get lower as we go on, but I would say this is still about maybe 80%, and this is maybe about 60%. So, and then the auscultation did not receive a lot of votes. So let's go to the next one. So this is how a Delphi situation would be carried out. Let's see whether we can do this. This is, what about examining a swelling? So if a student, if you were to write a curriculum that when a student is examining any swelling in any part of the body, they must follow these steps. I have written 6 of them here, and let's see whether you're able to, we can find some consensus about which one you would do first and which one you would do next, and so on and so forth. Let's vote. Are you excellent? Excellent. I think we are actually absolutely right. So you can see most of us chose number 1 as correct. Greet the patient and introduce yourself. Sanitize and wash your hand. Most of us say yes, that's what you will do next. Oh, some people have said, excuse me. Oh my goodness, I am running out of battery. Okay, so I'm going to stop now. I'm going to stop sharing, but you see how this is. I think most of us agree that greet patient, introduce. So a lot of us, there's some contention about greeting the patient or washing our hands. That's where there's a little bit of debate, which one we would do first. So I'm going to stop sharing. Stop sharing. So that's how this system would work. And so if you're trying to write a WBA, this is what you would expect to do. You would list the observable activities or behaviors that you want your students to be able to perform. That is, I'm assuming that you're writing them from scratch. Then you would test it, among experts. You will ask them to rank, and you can do that using a Likert scale or whatever. And then the results will come back. It will be done anonymously, and then the result will come back. And if you have 70% or more agreeing about your steps, then you would say, okay, that's valid, that's authentic, and that's what you would go with. So essentially, that is what I wanted to share with you. And the next few minutes was just supposed to be about discussion and questions. And I apologize if you see me drop off the call. It's because my battery has run out. I'm sorry about that.
No, not at all. Well, let's get straight into it then. I don't know if there are any questions from any of the colleagues on the call, but thank you so much, Prof. Oyèdélé. That it really is informative, because it's such a topical issue for us at the moment, WBAs, and how we can engage in it. Of course, just to clarify my understanding of using that sort of quasi-Delphi technique or the Delphi technique, of course, there's certain steps that won't be prioritized at all, not so, and therefore they wouldn't be part of that your list. So you're not only doing that for the sequence of the steps, but you're also doing it for which steps to include.
Yes.
Am I correct?
Exactly.
Yeah.
You're right.
Yeah.
You're correct.
No, and we might look to do that with some of our exercise, with some of our competencies. Of course, the evaluating the quality of the step is another exercise entirely, but that would need some consensus around that. That one would perhaps look at a video and be able to rank the students' performance on each of them, so that we could get consensus in that way, and sort of develop some inter-rater reliability. Correct. In putting it in that way, right?
Yes, so that's a separate step, like you have said. Yes.
Right. But can I ask you? I mean, you know what? And I confess that in the WBAs that we have at the moment and I was referring this morning to our Nelson Mandela Fidel Castro program, is we've introduced some WBAs, and how we've done it is we have included it as each being a low stakes summative assessment that we've then cumulatively added up in sort of something of a programmatic assessment, if you're with me, and that's been a certain challenge. Oh, I'm just wondering if your comments on that. I mean, it's worked in some ways and hasn't worked in others. Oh gosh, as Prof. Oyèdélé I think possibly his battery has run, finished its course. What's your sense, colleagues? Am I right? Has he dropped off the call? Or was it me?
I think he has.
You can hear me all? You can all hear me?
Yes.
Yeah. Just see if he joins us, but I'd just like to take this particular conversation forward because, Aviwe, you're in the clinical associates and the tablets when you're with the multiple different components that the BCMP students have to have as their SP. You're marking each of it's low stakes summative, isn't it?
Yes, we've got low stake, we've got summative, but for the SP, we use the assignment marks plus the mini CX mark, and those go together. Following a clinical rotation, mostly it will be those 2 marks.
It's just 2, whereas in the NMSC we have multiple different essentially mini CXs or snaps or DOPs, those 3, not or, and each of those. Sorry. And each one is assessed. Mervyn, your comment on I see your hand up, sir.
Thank you, sir. I think this is a very exciting subject, but immediately springs to mind the fact that there are so many people doing mini CX evaluations or DOPs or snaps, and they all have different either training or criteria by which they evaluate. So we might get a relatively inexperienced person giving a student an 8 or a 9, either from ignorance or from generosity, and the student doesn't actually conform in terms of the criteria that, without wanting to sound arrogant, you or I would expect from the student at a particular level. How do we go about dealing with this?
We do the faculty development. You recall in that TCT training that we did, and we all sit around the same video, and, yes. And we score it together and we discuss it, and we do it 158 times until we're kind of on the same page, or 5 times until we're on the same page. And I am just wondering if we can't, if one of these we need to, and perhaps Angie could take a note that perhaps we could use one of these sessions to just try that out with Aviwa's team on board, with yourself, Mervyn, and others, with a couple of the GEMP's coordinators, and we can just try to get on the same page, at least as clinical educators, as tutors, as coordinators. That would be useful.
I accept that. Absolutely, I accept that, and without question, I would love to be involved in that. But we then have to take into account the logbooks that we get that have been assessed by people who either have no interest or no experience at evaluating our students and have marked them.
And which is always going to be a challenge. And I mean, it is the and do we, until we can get the reliability across the board, until everybody can go through the training, can we have a way in which we at least have some benchmarks? And so we pick up complete outliers. I don't know. I'm open to suggestions as to how we can go forward. Daniela, did I see your hand?
Yeah, I was going to raise the same point that Mervyn had, but I think perhaps as an add-on to look at that mini CEX component for whatever's being assessed, and then what we assess in the OSCE. I don't know if we're looking at those particular trends, because interestingly enough, we found, students will have very good assignment marks, but then in the rotation test, when they're being tested to apply that knowledge that we assume they got from those clinical rotations, they don't speak to each other. So I don't know whether maybe it's something to workshop, or if something already exists where we can actually look at those trends and monitor it, and how do we address it? Is it as simple as just looking at the marks, or just looking at the objectives of how we design the assessments? Oh,
No,
Prof is back.
fantastic. Yeah,
Oh,
and I
that's
see that Prof. Oyèdélé is back. Welcome back, sir. We were just discussing with your excellent inputs. You sparked off a nice conversation around just the robustness or the reliability and the inter-rater reliability of these WBAs. Daniela, for example, was speaking about the OSCE at the end of the rotation vis-a-vis the WBAs through it, and how there's often such a differential. Mervyn was talking about just how we've got so many different assessors on the platform. How do we get some of this how do we get everybody on the same page? Perhaps your comment on that.
Yeah, so I can tell you of what we do, and I know you probably do the same. And because I remember that Prof. Lionel Green Thompson used to do something similar. There's this is it ANCOV method that's applied. So there's some statistical methods that are applied at the end of the OSCEs, for example, just to bring the rating towards a medium, to find a particular, an acceptable, to find something that looks like true consensus and true medium, and that's from where students will be graded, and not the actual raw scores. So I think you're right about inter-rater variability. Obviously, we train the preceptors, and there will always be some variability, but whether that variability is sufficiently skewed to invalidate the results or their ratings of students is something else. And as I said, I'm more aware of the fact that some statistical methods are applied to kind of more centralize people's individual ratings, and that's the method we use. And I know I haven't answered that question particularly completely, but the other thing that people also do is to like you said, test. So we test the instruments. Once you've developed the WBA or an OSCE framework, you actually test that. Like Richard was saying at the beginning, so you have like authentic students. Maybe this year, maybe this time not final year, maybe year 3. And I remember we did something like that in our school. So third year students, because you want to apply this at the final year, but you bring third year students to do the OSCE, all right, and you have preceptors rate them, and at the end of the day, you apply some statistics. There's some correlation coefficients and other types of methods that are applied at the end to actually see whether that is a valid instrument, and whether that there's you can the reliability, whether it's a reliable instrument, whether it's a valid instrument, and whether the inter-rater reliability is something that can be that is consistent with what we will call that's acceptable. And so, yeah, so the tool must be validated and tested. I think that would be a way to go about it.
No, thank you very much. I wonder if when they were introduced to the broader group of preceptors, those very same rubrics, was there something of a faculty development program that was introduced, or that everyone got in a room and did something of a Angoff around simulated case? Sorry.
Yes.
Yeah.
Yes, there was. I remember I was part of that group that did the initial testing of our WBAs. So, you know, actually this was our OSCEs, where like experts were in the room, like family physicians, internal medicine specialists, surgeons, so all kinds of preceptors. So a variety of preceptors with different backgrounds, but because the behaviors and the competencies being tested was at the basic exit level, so it didn't matter theoretically that these preceptors had gone on to specialized, and so we tested the students, you know, so the students who come into the room just as a standard OSCE, and at the end the data was collected, and then the statistics methods applied. And I remember that there was a robust debate about which method to use, and eventually I think it was the Angoff method that eventually was settled upon, and that proved to be reliable. So the tools proved to be reliable and consistent.
Are there any other final questions? Thank you so much. Are there any other? We're drawing to a close over the next couple of minutes, but just until I see another hand. Oh, there we go. Daniela, do go ahead, ma'am.
Okay, I thought it's faster to just do it this way. I'm just thinking about the capacity. Yes. And then who do we target? Because we have such a high staff turnover in our training platforms, especially for BCMP, where the mini CXs are done by preceptors that are working at the training platform. So we, you know, sometimes you have the mini CXs being done by perhaps a registrar or an MO. We come back the next year, they're no longer there, or a consultant, and they're no longer there. So maybe something just to, who do we target? And then how often do we do it? Do we do it just at the beginning of the year, or do we also try and do it, you know, halfway through the year?
So if I get the question, you're asking in terms of the people who will actually examine the students, because there's such a high rate of turnover. So when you are trying to validate or test the reliability of the instrument, then who should you target? That's a difficult question. That's a really difficult question. I guess you use whoever you have. That's what ends up being the case in a lot of situations. You're pragmatic, as long as you document the limitations of the steps and of the process. You just use whoever is available and whoever you have. So if they're residents, if they're specialists, if they're MOs, you just use whoever you have, and you document the process and be as explicit as you can be. There was another hand.
Was there? I didn't see that. Anybody else? Yeah, Mervyn, good to go ahead, sir.
Thanks. I don't want to waste time, but I'd like to ask Prof if there is any specific method for giving students feedback as a result of this evaluation, because this is probably as critical as doing the evaluation. Thank you.
Absolutely. Thanks, Mervyn, for that question. And you know as well as I do that people have used all kinds of methods, the sandwich method, the one good thing, compliment, and then criticism, and then a compliment at the end. And yeah, there are several methods that are out there in the field. What we have found, and what our students, in fact, I just finished a study on our, this time, of course, not our clinical students, but on our preclinical students, their feedback during CVL. I just finished a study where one of the questions was, what kind of feedback is effective for you? And it will not surprise you to find out that a lot of students appreciate a narrative feedback. They appreciate the preceptor actually going to tell them this and this and this and this. So to itemize the things that they are doing well, and to itemize the things that they could do better. So they prefer that kind of specific feedback that has some action item, something that they can take away and do, all right, rather than just oh, good job, you're doing well, or continue to improve, like something that is vague. So students prefer. In fact, I was pleasantly surprised that the students said in that survey, they said, "Don't be too nice." That was actually an actual quote that the students gave us. Don't be too nice. Tell us if we are wrong. That is the only way we can improve. And so the students actually prefer. That's why in the examples that I showed, there is a box. There is a narrative box where preceptors can actually write in long form what they have observed, what the students can do better. So whatever the method of feedback that you prefer, I think it should always include a narrative box where you can actually specify the observable actions that you feel that the students could do, or the steps that they could take, and students will appreciate that. Yeah.
Excellent. So thank you so much. I'm afraid we've run out of time. Just as a closing comment, I wanted to note that colleagues on the call, you're reminded of the contents of the TCT, the Train the Clinical Trainer modules that we've all engaged with. Those that haven't, just running my eye down the list in terms of, certainly out of the DFMPC, you need to flag as such, and we must sort that out. But to note as well that we presume that our WBA tools, the mini CXs, the SNAPSs, the DOPSs, are, and appropriately so do we presume it, that they are validated. However, it's in the use of those by the individual preceptors that then we need to do the faculty development. However, we're moving into an era of EPAs, the Entrustable Professional Activities, colleagues, and those are being put together. So then when it comes to the WBA, to assess that EPA, which is a fairly new concept or new practice, those will then need to be validated appropriately. So we've got that work ahead of us more, but perhaps at the for the postgraduate space at the moment, in terms of the current conversations. But I know, for example, in the BCMP space, that where the curriculum is particularly around the third-year competencies has been developed around EPAs. So that's food for thought in terms of how where we are and where we are heading. Prof. Oyèdélé, I must thank you very much for your inputs. We're really grateful to you for coming onto this professional learning series this afternoon. I do just want to give a nod to the Carnegie program, the Alumni Diaspora program as well, in that it's through that program that you've been that you've joined us from British Columbia on your trip, to acknowledge that. And I understand that you're here with us until the 28th, if I'm correct.
Yes, I am.
And if we're still wanting to perhaps engage a little bit early next week or later this week, we might be able potentially to have another possibly one-on-one or even a group conversation late to arrange at this stage. But I might be getting in touch with Mohammed Patel, Dr. Patel, to do that at the request of colleagues on the call potentially.
Excellent. That would be great. Thank you.
Brilliant. Well, thank you again very much for your attendance, and very grateful. And thank you everyone for attending this afternoon.